Go. Okay, welcome back everyone to our final session of our two-day 16th Annual Benefits Forum. Thank you for staying the course. Thank you for being part of this. We are going to start a little bit early instead of starting at 4:10. We have all of our speakers here and they probably are as eager to get this over with as you are. And actually, I think they're just eager to share their information with us, but we don't want to hold you up too late tonight. So what I'd like to do is, Holmes Murphy is one of our sponsors. We're absolutely delighted to have their support, as they have for many of the past years for this, maybe all of the 16 years, possibly, Wally, would you say? So yes, they're loyal supporters and we always appreciate their being here. And they also are always willing to go last. So this is great. It works out well for us too. So Wally, who's been working with us for a long time in many different capacities and lots of wonderful advice that he shared with us over the years. I think, Wally, you want to do an introduction to somebody we're about to meet.
Marianne, that sounds great. And good afternoon to everyone. Nothing can slow the business group on health down, not even a pandemic. So it's great to be back with everyone again this year, even if it is virtually. But before we introduce our session speaker and our next topic, I did want to take a couple of minutes to introduce you to the new market leader for Holmes Murphy, Texas, a very good friend and business partner, Mr. Brad Bierman. And Brad, talk a little bit about your role and what you did prior to becoming the practice leader for Holmes Murphy, Texas.
Yeah, thank you, Wally. It's been a blessed 18 years at Holmes Murphy. Was hired right out of college. Didn't know what was up or down, but found my way doing a few different things inside of the organization. My dad was a small business owner, and I have a strong entrepreneurial spirit, and have been blessed to be involved from the very beginning in the founding of ACAP Health. And before my recent return to the mothership, as we call it, spent some time as the CEO of Naturally Slim, really working with Marcia to find a partner that could take that business to its next level. And I'm very blessed and lucky to have worked for one organization for 18 years, and I keep telling the folks around me, as long as people will put up with me, I'd like to finish my career at Holmes Murphy. So very proud of what we do.
Well, Brad, you've had great success over the years. When you look downfield, what do you see are the biggest challenges for Holmes Murphy in the industry moving forward?
Well, I got a negative COVID test today, so I will check that one off as that's not a challenge today anyway. But I think the answer to the Wally it shouldn't be shocking or surprising, and I don't think it's changed in my 18 years. My passion has been around making a difference at the individual level, and you just can trace everything that doesn't work or does work back to the difference we make for the human that at the end of the day is the equation. And so addressing the underlying health in our membership. And, that was part of my passion in joining with ACAP and, working with Naturally Slim. That was awesome to wake up every day and know the difference you were making. You could really tie it to concrete clinical health. I would add to that, this year has been a revelation for me on the mental health aspect. And, the opportunity we have to really lean in and support, the whole person, which could include, we've been doing a lot of purpose work with our customers and helping them around, having happy, connected, engaged workforces. And that's awesome time when we get to spend that with our customers.
Thank you, Brad. So last question and the most important one, tell us a little bit about your family.
Yeah. This is a cheat because Wally and I talked last night and I shared, I'm blessed. I've been married for 19 years, approaching that 20-year mark, and I have 3 kids, 2 boys and a girl, 11 to 5 years in age. And I was sharing the greatest source of stress right now is my 13-year-old is into competitive baseball, and he did get an offer last night from one of the top teams in the area. So we're sort of deciding whether that's a good thing or a bad thing for our family, because it's a whole nother level of commitment, and want to do that for him, but also nervous about what that means for our obligations. And it's a little bit more like a job, and can he keep his passion for that sport even at that level of commitment? So I will say this: that the COVID has been really weird in so many ways, but there is the extra time that I would spend with my family that I wouldn't have otherwise, that has been a small blessing coming out of this really hard year.
Well, you've been a great leader and a great dad and husband. Congratulations on the new role, and I know you're going to do great things for Holmes Murphy and for the industry. So
we're excited. We got a lot of work to do. I'm excited about this organization's mission, and looking forward to being engaged. Hopefully, meet people in person at some point next year.
Awesome. Now I get to also turn it over to a friend and longtime colleague. So Alice, I'll turn it over to you to introduce our next topic and session speaker.
Okay, Wally, thank you. We are, long time makes us sound old. Of course, we're not. Anyway, so I'm pleased to introduce Den Bishop. And, in this audience, he probably doesn't need an introduction per se, but I'm happy to provide that. And Holmes Murphy has been such a dynamic organization in the Metroplex for many years. And Den is leading that company. He's on the executive committee. He's also co-founder on ACAP Health, and a member of the Council of Employee Benefit Experts, serves on the board of C2 Solutions and the Dallas Regional Chamber. So that's got to be interesting. He wrote the book on healthcare reform. I have a copy. If you haven't gotten a copy, you need to get it. He's a recognized speaker, went to SMU and was at SMU, was a tennis player. Is that correct, Den?
That is it.
That's something we don't hear about often. So you might want to expand on that. So welcome, Den.
Thank you, Alice. Glad to be here, and glad to be sitting in the final spot. So it's between me and the grand prize drawing. So we will make sure that we stay on point and on task. And I really appreciate you staying with us, because these long Zooms as we continue to go on can be a little difficult. So hopefully we'll have a little entertainment, maybe stimulate a little thinking about how some of these pieces of delayed care, COVID, and what we do next. So hopefully put a good wrapper and bow on all you've heard for the last 2 days. So go to the next slide. All right, and we'll go to the next one. All right, so if we were doing this a year ago, the term social distancing is probably not something all of us would have had a good, strong definition of. But in this year of COVID-19, we know social distancing isn't something that the teachers at a junior high try to impose on their students who fall in love in middle school. Social distancing is this practice of staying apart in order to stop the spread of disease, specifically COVID-19. Next slide. So all of us in our workplaces have put up signs like this one. This is just one example, trying to educate our workforce on what they should and shouldn't do. That's also in every restaurant we go to, in every store we go to, any building we go to. It's really a different view of how we look at disease as society. I mean, I'm guessing as folks in HR and in benefits, you really didn't think that you would spend, the part of the first quarter of this year searching for hand sanitizer to put in your workspace, or trying to figure out how to get a long-term disinfectant to work, or figuring out all of these things about how we could have people in the office but far apart, and what are our policies and rules, and what app are we going to use to track that. There's all this stuff that we've done around COVID-19 because we figured out, because the media kind of told us that COVID-19 is a really bad thing. It's this frightening disease that you don't know how it's going to impact the individual. So if you really care about the people with whom you interact, whether that's your friends, your families, your coworkers, then you will do your part to try to fight COVID-19. That's kind of how this has all gone. But our role in business, in how we look at how we attack disease, has really changed based on what we've learned from COVID-19. And I want to talk about how all of that applies. Just to give you an example and kind of tease you where we're going to go. Right now, we've got, I think the latest data I saw this morning was 274,000 people in this country have lost their lives to COVID-19, 274,000 this year. So it looks like if the numbers continuing, we'll be just about 300,000, maybe a little over 300,000 people in the United States will lose their life to COVID-19 this year, an amazing tragedy. But to put it in context, if we hit that 300,000 number, which I think we will, probably surpass it just a little bit, then that will mean half as many people in the United States die this year from COVID as from cancer. But cancer doesn't get all of the attention on the media every night about how many people that twice as many people are going to die this year in the United States from cancer as from COVID-19, even more than that from cardiovascular disease. So these other conditions that we in the benefits world know drive the cost of everything we do, don't get the great attention that COVID has gotten. But maybe we need to take what we've learned in how we fight COVID and start applying that to cancer and cardiovascular disease and diabetes and other conditions that are taking a lot of money out of our businesses and quite frankly, killing our people. If we care about each other, we will figure out how to fight these diseases in the same way we have fought COVID-19. So if you go to the next slide. There's another new term, hit it one, there we go. Another new term that I made up called clinical distancing. And this is an outcome of COVID-19. So where social distancing, we all know what that is. Clinical distancing is this practice of delaying or avoiding clinical treatment because you're afraid, confused, you might get COVID. So you're just not going to go to the medical facility or to the doctor's office because things might get worse. That has occurred. And so we've seen that in the loss ratios from insurance companies. The refunds in the insured market are projected to be in the billions of dollars based on the fact that loss ratios across the country are very, very, very favorable. And because of the Affordable Care Act and in the insured world, the insurance companies have to refund their customers. So that's a 3-year kind of blending on the payout. So don't expect big checks one time, but there will be billions of dollars refunded because people didn't get care. So how has that played out? Who didn't get care? And if you'll go to the next slide, there's a recent study, and the title of it is here. The survey tracks COVID-19's effects of delayed medical care. And the first line of this headline, I think, is almost staggering, that more than 40% of American adults, actually in the study, it's 41% of American adults said that they have avoided or delayed care because of COVID-19 concerns. They were afraid that if they went and got treatment, that they might catch COVID, and so I just didn't go. And so you think about that, and you go, wow, 41% of American adults didn't get care they felt like they needed or should have received. If you go to the next slide, the problem is who made that decision. So inside of the study, they looked at the participants and said, if you don't have any chronic medical condition, then 34.7% of the population avoided care for the healthy folks. For those that had one chronic condition, so they have hypertension or they have diabetes. The population that has one, but just one chronic medical condition, 41% of that population avoided or care because of COVID-19 concerns. But the population that we all know, that multi-chronic population, that part of the population that you're trying to get in a medical home, that you're trying to get connected in the healthcare system, because they have multiple chronic conditions that they're fighting, and their bodies are breaking, and that's where the large claims come from. And those are the people who need the most help. A staggering 54.7% of the population with 2 or more health conditions decided this year that they were not going to get treatment because of COVID-19. So we have this kind of toxic mix that's sitting out there in the health of the entire population, that those who need care the most are the ones who most frequently have said, I'm not going to go. I'm not going to get it. I'll skip. I'll get it next year. Maybe nothing happens. And you put on top of that the anxiety and the mental health issues that are flooding the country at this point. You realize that the risk profile that we are all looking at in terms of what's inside of the groups that we're covering inside of our population, our risk profile today is significantly worse than it was a year ago, based simply on the fact that we know the people who really need this ongoing treatment have chosen not to get it. Now, we don't know by population, by company at this point very well, but we do know in the population that is what has happened. So if you go to the next slide, if you think about this and you think about this thing that's happened, so we've got the population out there that needs help. We know they need care. We know they need to be seeing their doctor. They know they need to be getting these tests. We know that they need to be taking their meds. And now they're not at a rate that we've never seen before, the slowdown. Whose job is that? So whose job is it to try to deal with this lack of care that has occurred? So in our terminology, and this is a cartoon from my latest book, and so it's all about whose role is it, and there's different roles. So Uncle Sam in the cartoon here is tossing a toilet paper roll. That's a role. A Tootsie Roll. That's a different role, and a cinnamon roll. There are different roles, so you got to decide whose role is it. So who is accountable for the health status, choices, behaviors of your covered population? Is it the insurance company? Maybe. Is it physicians and hospitals? It's kind of like the last discussion with American Airlines and Aon and Baylor Scott and White, how we've transferring this responsibility connecting there. Is it the government's role to get this solved? Is it the employer's role, or is it nobody's role? In COVID, it really became the government's role, the media's role, the employer's role. Everybody stepped in to try to help the population understand, here's why you need to wear a mask. Here's why you need to stay 6 feet apart. Here's hand sanitizer at every door. Here's all these things. Everybody kind of said, hey, it's our role to try to help slow the spread of COVID-19. But whose role is it to try to slow the spread of type 2 diabetes? Whose role is it to try to identify cancer faster? Whose role is it to avoid a heart attack or a stroke? It's these questions that we have to be asking ourselves. So if you go to the next slide, if you think the country in general, then the Center for Disease Control, CDC, has said for decades that the health of the United States is our job. They said it's their role. So in essence, they would be the ultimate employer. They're the employer of America in terms of trying to manage this risk pool in the same way you try to manage the risk pool in your population. So recently, if you remember, there was Healthy People 2000, and an awful lot of goals we didn't hit and some we did hit. Then there was Healthy People 2010. Then there was Healthy People 2020. And now there's Healthy People 2030. Very specific goals for the population in the United States. I believe what the Center for Disease Control has done through Healthy People 2030 is a fantastic model to maybe help us as employers and as plan sponsors and as consultants and as medical providers to figure out well, how do we get specific about what we want to solve? With COVID-19, we got very specific with how we were going to try to prevent the spread, what we were going to do if someone contracted the disease, the contact tracing. We got very specific in COVID-19 about exactly what we were going to do to try to help fight this disease. We are nowhere that specific with any other condition. But let's talk about what Healthy People 2030 is doing, maybe lessons we could learn. If you go to the next slide. So Healthy People 2030 has 5 different categories that they put all of the things that they're studying. So it's the health conditions, everything from addiction to osteoporosis and overweight. It's got health behaviors. Are people sleeping? Are they using tobacco, getting vaccinations? It's got those things. It looks at the population, things that are specific to a given population. It looks at the settings and health systems themselves and what's performing there. And then it has this new term that we've all kind of been wrestling with last year too, the social determinants of health. But what are the other things that are driving behaviors that aren't really the healthcare system, but impact how that works? And inside of that, the CDC has 355 specific goals and targets for the population. Now, one thing I can guarantee everybody on this Zoom, if you try to have 355 specific health targets, you are not going to get your executive team's attention on how to pull these things off and the resources to track and to monitor and do all that. So you have to decide what's important in your population. How do you decide? Well, you look at your data. In the last discussion, that was part of what was there. So you look, is cancer a problem? Great, get specific on cancer. Is musculoskeletal pain and musculoskeletal treatments a problem? For the vast majority of you, it'll be your highest cost condition. Is it healthy babies? Is it cardiovascular disease? Is it stress and anxiety? Is it your polychronic patients? That you've got to look at your population, the diseases that are happening, and then you've got to get specific. So let's use the Healthy People 2030 as an example of what maybe we should be thinking about as employers. If you go to the next slide, I picked an easy one on this, not controversial. So this is one of the 355 targets that they have for 2030. So it's C, which is their cancer code 07. So this is the 7th of their cancer targets. And so what I picked as our example here is colorectal cancer screening, getting your colonoscopy, which everybody on this line probably knows that age 50, without other risks, it is suggested and a best practice for adults to have a colonoscopy to get a baseline, and then your doctors from that point will tell you how frequently you need to come back based on what they find. When I was age 50, I had my colonoscopy that was there, and there were no risks associated with that. So they told me that I am good until age 60. So I have a 10-year window that's there. So that's how that works, and all of us probably know that. But here's the simplicity of what Healthy People 2030 has kind of taught us. Is they said, okay, here's our target. It's to increase the proportion of adults in compliance. Easy. We would all probably say that, but we get less specific in that. So they have a baseline that in the United States, 65.2% of American adults within this age are compliant with this guideline. The target is to raise that to 74.4% by 2030. And then they have their data source. They know exactly what they're using to measure in order to see whether they're on track or not on track. A very simple business model of how to track performance that, quite frankly, I see in very few employers. We overcomplicate things, or we don't own our role too often, and then we end up not getting our results because maybe we weren't specific enough in what our targets are. So if we go to the next slide. So in my recent book, and when I talk about this, I will very often in my last Dallas-Fort Worth business group on health session, I talk this, but I want to give this audience this because I think it's hopefully something that will help you realize what our opportunity is around trying to help people who are delaying or avoiding care. And it's what I call the T-Rex effect. So the defining physical characteristic of a Tyrannosaurus Rex is their little T-Rex arms, right? So if you think of movies, they got these massive legs, massive bodies, huge heads, and little bitty arms. And so the T-Rex can't even lift up and touch its own chin. I mean, their arms are so short. And if you think about healthcare, and you think about what's happening, or the choices that many people, that all of us cover, they're in our plans, that the care is available. There's great quality doctors. There's great quality hospitals. There's phenomenal medicine. There's amazing tests to try to uncover things. The quality of care in the state of Texas is phenomenal. The access that we have is fantastic. There's great hospitals, there's great doctors, there's great training, there's great technology, and yet our healthcare outcomes aren't very good in spite of that. And it's what I call the T-Rex effect. And so what the T-Rex effect really is, if you think about this dinosaur, let's assume that up on the wall, there was a red, kind of like an easy button up on the wall, and it's a survival button. So all the T-Rex has to do is reach up on the wall and push the button, and they miraculously get their cure, and dinosaurs don't become extinct. But we all know, except in movies, dinosaurs are extinct because the button or the cure was available, but it was just slightly out of reach. And so the dinosaurs died anyway. And that's kind of what's happening in healthcare, is that there's all this great care that's available. And yet for too many people, for a host of reasons, it sits just out of reach. And so they don't get the medicine they need, or they don't get the screening exam. And so the cancer gets diagnosed at stage 4 rather than stage 2, or they don't get their high blood pressure taken care of because they felt fine, and then they have a stroke instead. That's how they discover it. It's the tragedies of this lack of connection inside of the healthcare, because the care is available, but it's just slightly out of reach. So if we go to the next slide, the number one reason that it is slightly out of reach, and this slide didn't translate well, so I'll move quickly on this. What this slide is speaking to is the number of Americans who are inadequately insured. And what inadequately insured means is that they have health insurance, the vast majority of them through their employer, but they don't have the economic means to meet their deductible and out-of-pocket exposure. So over time, this number of Americans, and this is from a Commonwealth Fund study, the number of Americans who are inadequately insured, they have health insurance, but they can't afford their out-of-pocket, so they are not getting care. It's gone from 15 million to 29 million, and it's estimated, and this is a 2018 number. It's estimated at 44 million. My projection is right now with COVID and what's happened with that, we're probably sitting at about 50 million Americans that have health insurance but don't feel like they can afford to go to the doctor. So that's one of the things. And as an industry, I think we always go to it and go, oh, it's plan design. If we'll just change our plan design, then people will get the care they need. And I want to tell you, I don't think it's necessarily always plan design's fault, but plan design is a place to start. And we need to think about how well people understand the plans they have today. And that a great example of the misunderstanding, if you just think about in political campaigns, how the discussion of pre-existing conditions has been handled in the last 2 elections. It's been absolutely politicized to the point where people are afraid they're going to lose their pre-existing condition protections, when that really hasn't been a threat. Every Republican proposal, every Republican proposal was short on details, but they all protected pre-existing conditions. But patients don't understand that. And so the fear that people have around what how things work because they don't understand how it works, can work against them getting the care they need. If we'll go to the next slide. I want to talk a little bit about those things, though, beyond your plan design. And I want you to think of COVID on this. So, this concept of social determinants of health, and what it really gets to is if you're looking at the health of a population, how much of it has to do with healthcare and with insurance, and how much of it has to do with everything else in a person's world. That's really what this whole topic is about. And what the studies have shown is that the healthcare system, access to the healthcare system and the quality of that healthcare system is estimated to be worth 10 to 20% of the total health of the population. And everything else is worth 80 to 90% of how healthy a population is. So if we use COVID as an example, on the social determinants, we start with education and the quality of that education. So areas that have a more educated population are healthier. That is one of the determinants. So if your covered population is more educated, you got a check mark in the good box. If you've got a less educated population or a portion of the population that's less educated, if you're trying to get to the same health goals, you're going to have to do more heavy lifting. It's just a fact of a social determinant of health that education impacts as a baseline the health of that population. The second is healthcare access and quality that's there. So if people are in an area with access to great healthcare, that's worth 10 to 20%. In Texas, most areas, other than some rural areas, have access to there. The next area, the neighborhood and the built environment. So is it an area where people can walk? Are there food deserts? It's that whole social piece of where someone lives. That drives them. Then your social community and context. Are people socially connected or not? Again, this has been highlighted by COVID. And then the last piece of it is economic stability. Can people afford to go to the doctor? So that's social determinants of health. If we'll go to the next slide, I want to introduce a new concept that I made up called the corporate determinants of health. This is the stuff that you either own, influence, or need to be aware of with every decision that you make. So I'm going to say that again. Everything that you think about in terms of these determinants of health, you need to decide as an employer, do I own this? Like plan design, you own plan design. Can I influence it? I could influence whether or not people will have a primary care physician. Or is it just something I need to be aware of? The schools in the neighborhood in which my people live might simply be something I need to be aware of that. So I can't necessarily do anything about it, or at least short term, but I'm aware that that's going to create my challenges. So my first filter, if you're thinking about how to start addressing things, is do I own it? Can I influence it? Or am I just aware of it, but I need to take other actions related to this? So here's the COVID test. From COVID, did you do anything to educate, understand, or help your people navigate what to do around COVID? Universally, the answer to that is yes. Employers said with COVID, we have a responsibility to educate our people, put signs in the building, do other things to help people understand what to do. We've got an app, and in your app, you need to do this. If this happens, here's the contact tracing. We got more involved as employers in helping people understand and navigate the healthcare system with COVID than we ever have any other condition. But are there things we did with COVID that we should think about applying other places? I say yes. So the second place, healthcare quality and access. How much access has been there? How are we paying attention to access? Well, we now know that the measure of 15% of hospital beds are occupied with COVID patients, then we're in the red zone in total healthcare, so we're looking at access. But if we're thinking about how our people are accessing care, what percentage of your population is receiving their care from high quality or tier 1 providers? And I don't care how that tiering is determined, whether it's a Blue Cross tiering, a United Healthcare, an Aetna, a Cigna, an Independent, a Grand Rounds, a Quantum. Let's set aside even whose measure, but are my people accessing the best quality care? And if they're not, how am I measuring that? What can I do about it? We've got to think about those kinds of things. Work and home environment with COVID. Use that as an example. So we are very conscious of how close our people sit in the office now. We weren't before. We are very conscious about a lot of things about where and how people move within an office, how close they are. We have thought about how our work environment impacts the potential spread of this disease. Are we thinking about how our work environment potentially spreads the impact of obesity or of other or musculoskeletal pain? We've got to think about what we're doing in our workplace that actually impacts the disease across the board. And then cultures, policies, and engagements. So we've all looked at our work flexibility plans because of COVID, right? We had to rethink our policies around paid time off and leave and flexibility of work schedules. We had to rethink everything because of a disease. Have we really thought about those same things in terms of other conditions? And I think there are places where we can do better if we just think through that. And then the last piece of it is the obvious, the one we always start with, which is plan, design, affordability. Can people afford to go? Do they know what's there? So in my last couple of minutes, let me kind of give you the playbook of where I see all of this going, how we as employers can own our role. And in this, I'm speaking to this as president of Holmes Murphy, a company with a little over 1,000 employees. I own this, as part of our executive team in terms of how we are doing this for our employees. So I'm speaking to it from that perspective more than as an advisor working with other companies. I want to own this whole issue and area within our population. So let's go to the next slide and kind of, I'll give you the playbook. So there are 7 critical steps in the slide in the translation. It chopped it to 6. So I'll talk through the last. So the first place, if you think back to the Healthy People 2030 slide, they had 5 different categories. You as an employer, when you receive data, you receive it from multiple points of view. So you'll get information by size of claim. In other words, here's all my high cost claimants. Every claim over 50,000 or 100,000. Here's everybody under 1,000. So you'll look at it. You'll get reports on setting. And what I mean by that is here's how much was inpatient. Here's how much was outpatient. Here's how much was professional. Here's how much was lab. Here's how much was pharma. It's all based on setting. And then you'll get things based on the primary condition. Here was where the primary condition was diabetes. The primary condition was cancer. You have to look at this and rethink how you look at data. And I want to talk about it in terms of baseball. So baseball works because there's order and consistency. The batter can't say, I want to bat from first base, or I want to run to third base first. You don't have that flexibility. To play the game, you always bat from home plate. And you always have to run to first and then second. And so there's order about how you do that. You have to start looking at your data the same way. You have to pick whether it's a disease condition, a size of claimant, is it another population measure, or is it setting based? I strongly encourage you to consider the disease condition as home plate. Always start with that. As in COVID, when you started thinking about how to respond to COVID, you started with a condition. What do we need to do to fight condition? Then you started thinking of all the other areas and places. But you took a specific focus because you knew that disease was your enemy. And here's everything you're going to do as a company to try to prevent the spread and then help people deal with it if they get it. If we took the same thing there. So in our condition, I'm going to use the same thing in my 2030. Let's use colorectal cancer. So we pick our base. My suggestion is the condition. The second thing we do is we identify our stage. We have to get very specific. And I can encourage you to look at 2030 for great example, the Healthy People 2030 for great examples. So it could be prevention, it could be detection or identification, or it can be connection. Those are the three things. So if you are focused on, in our example, colorectal cancer, are you going to focus on the prevention, the detection, or the connection? If it's screening, cancer screenings, that's the identification or the detection. And so you could have a goal on that. You could also, around other cancers, say we have a prevention. Well, how are you going to prevent that cancer? Well, for some cancers, it might be obesity-based. For other cancers, it might be tobacco-based. It could be, so you've got to figure out, are we dealing with prevention, identification or detection, or connection? And connection simply means that once someone has been identified with a condition, whether that's cancer, cardiovascular disease, musculoskeletal pain, anything else, the best thing you can do once they have it is get them connected to the highest quality provider in a way that's understandable and affordable. So if we forget everything else we say about how to help people who have a condition, get them connected. So let's help prevent, let's identify, and then let's connect. So that's the second piece. So we pick our disease, we decide with our specific measure, are we going to focus on prevention, detection, or connection? Then we have to do exactly what the CDC did with their 355 measures. They identified a desired result. They said, I want to increase screening prevalence. So that's the example I'm using here. It could be anything. If it's helping people who have type 2 diabetes, it could be increasing the percentage who have an annual eye exam or foot exam. It could be compliance with pharmaceutical prescriptions. And so you can pick what your desired result is, but you have to be really specific. Then you have to establish a baseline. Use your data to figure out where you are today. This is the way your executives think about everything. It's what are we trying to achieve? What's our baseline? And what's our target? We have to do better when we're talking about health of getting very specific about what we're trying to do. And that is getting time specific and number specific. Then we do what I call my corporate determinants of health, the CDOH analysis. That's thinking of everything about our company, our policies and procedures, our workplace, the education and understanding of our people, our plan design. What's everything that we're doing that is either building a ramp to make it easier for people to get the care they need, or it's building a hurdle to keep them away from the care they need. And oftentimes the hurdles aren't on purpose. But when we have complicated plan designs, or we don't adequately communicate, or we have some kind of crazy, you got to go through all these steps to get to something that's there. We don't mean to do it, but we've kind of done it. People don't, for the most part, love the plans we have created and the way we do it. If you think back before Super Tuesday, Bernie Sanders was going to win the Democratic nomination. That was the path that it was headed on. He had one platform item, and that was Medicare for all. He didn't really have anything else in his platform that he talked about. Everything he talked about was Medicare for all. What was Medicare for all under Senator Sanders' plan? It was free. It didn't cost you anything when you went to a doctor or hospital. There were no deductibles, no copays, and it was free. You didn't have to pay any premiums. So it was this free plan that was there. Now, does that really make sense? And could be there, nothing is free. I mean, you can't take 18% of GDP and make it free. So intelligent people could think through that, but that was how it was marketed. And he was going to win the Democratic nomination. He had momentum. The moderate Democratic Party was divided among candidates, Mayor Pete, Amy Klobuchar. I mean, it was spread out, and so Joe Biden was trailing in that. If you remember in Iowa, where it all started, Joe Biden finished 4th in Iowa among the Democrats. He lost to Elizabeth Warren so he was not doing well. But when everybody else got out in the moderate area, all put their support behind Joe Biden, he was able to overcome the movement that was really healthcare based. So we've got to think the way that Bernie Sanders thinks. What do people not like? Now, we can't have it be free, obviously. So in my colorectal cancer example, that is covered at 100% under every one of our plans. So, but do people understand that? Probably not. So we don't need to change our plan design to get compliance. And we might not have to put punitive penalties, but maybe we do. We have to think about those kinds of things. But maybe it's just helping people understand. But maybe, and we found this for a few employers where we've had a significant uptake, they figured out that the hurdle was paid time off. That when people have to use a paid time off day to get their annual cancer screening, they don't want to use the paid time off day. So it's a policy, it's these other determinants of health we have to think about when we're trying to address a specific clinical item. We want a better result with this, whatever this is. We have to think about each of the categories, and is there anything in these unrelated categories to our plan design that actually could create a ramp or a hurdle? What's getting in the way of people getting in the care, or what is helping them get the care? For our customers who have added a free paid time off day on the date when you get your annual cancer screening, we have seen those cancer screening rates go up dramatically. Much better than if you have a very punitive system that says, I'm going to charge you $1,000 more if you don't do what I told you to do. Those kinds of stick approaches, yeah, they can be effective, but people don't like them. And if we're in benefits and HR, then they don't like us because they associate us with those plans. So I think we can think more creatively if we think about everything that we do that contributes to that disease or to fighting that disease. In the same way, when you started thinking about COVID, you thought about everything. We have one customer who discovered that in an early COVID spread, it was flowing through their ventilation system because they didn't have filters in place. We would have never thought about that. It's forced us to think about all of these things that might drive disease. We need to think about those same things for cardiovascular disease, healthy babies, cancer, heart disease. We need to think broadly about all these determinants of the health. And then the other piece, I'll kind of go back to number 5, is communicate your target. Once you've picked a target and you've said, for our population, if we said diabetes was a big deal, and we said, we're going to look at everything we can do around prevention, detection, and connection. We get specific plans for each, specific measures for each. Communicate the targets. Tell your executive team that by the end of 2022 or 2023, we currently see this percentage of the population not getting the care they need. We are going to close that gap, and by the end of 2022 or 2023, we are going to move that from point A to point B. Your CFO and your CEO will be elated that you are talking business terms about how to move the health of the population. And they'll understand why, because you say, we see in our data that these people need help. They're not understanding, they're not getting the care they need. They're going to low quality providers and getting unnecessary procedures. You can then build a story that raises your perception and perceived value and real value with your executive team. That's where we need to go. But if we don't communicate our targets and the data of how we're going to get there, they're never going to know where we're going. And then they're going to look at it every year and go, another stop loss increase? And how are we going to trim plan design? We've got to evolve these discussions. But that's the way you do it. And then you communicate with all your stakeholders. So those stakeholders, who are they? They're your consultant who will be involved in the discussion. They're your insurance carrier. If you've got a direct primary care relationship, if you're using Quantum or Grand Rounds or any of the other service providers that there, what if you got everybody together and you said, here's our baseline, here's our target. Now let's all work together and hold ourselves accountable for achieving a better measured result. That's how we need to evolve how we're going about getting the care that people are delaying. If we go to the last slide. So my last slide, and I always end with this, and it's again back to the rants and hurdles. Those of us, which is all of us, that are in the financing of healthcare world, the employee benefits world, we just have a phenomenal opportunity to positively impact people, but I don't think we give ourselves the credit because we spend too much time trying to figure out who to blame. So on one side, we want to blame the doctors or hospitals. Oh, it's a low quality doctor, or it's an expensive hospital. Oh, it's their fault that this is happening. So what are you going to do? Are you going to change, that it's going to work? No. Or gosh, it's the insurance companies. They're just making so much money this year. It's their fault and they just won't listen. And so I'm going to change from one to the other. And does that solve your problem? Typically, no. It's value you get anywhere or you don't get anywhere. If you're a Republican, you think it's a Democrat's fault. If you're a Democrat, you think it's a Republican's fault. And Joe Biden has been elected president. And yes, there's a vaccine coming. And it's going to come in time that he's going into office. He had nothing to do with that. And it's not Trump's fault that we got COVID. I mean, we politicize it, and it's not politicians' fault. And then we say it's the no good patients who they're not doing what they're supposed to do. And then we're going to put bigger punishments in place. And, it's not their fault. The problem is there's this one enemy that we have. The enemy is disease. So sitting in the middle of it, we need to make sure in every decision we're looking at whether we make it easier or harder to measurably win this war on disease. And we've done it and done great in all of our workplaces around our war on COVID. I want us to take what we've learned and apply that in other conditions. Thanks for the time today. Hopefully this has been thought-provoking. I always appreciate the ability to talk with you. And Mary Ann, I'll turn it back to you. And thanks for allowing Holmes Murphy to support and participate again this year.
Thank you so much, Dan. That was superb. I love the way you put in perspective, who's to blame? And it's sort of like who's to blame for COVID not coming under control. I think it's all of us. It's nobody's responsibility. We all have to be involved in this. So that was great. It's the same with healthcare. So thank you so much. Really appreciate it. I was going to say I have no questions, but I do. There's a couple popped up. Okay, so one question is, so can we also conclude that lifestyle is a major factor to combat these comorbidities and prevention?
Yes, absolutely. So if you think about the determinants, that the lifestyle, although not in the official social determinants, if you think about lifestyle as being an impact, absolutely. Dr. Scott Conard, who many of you know, I've been fascinated by his view on this subject, is that he talks about how our behaviors connect with our genetics, and that triggers what happens. So part of it's our gene pool, but the other part of it's the choices that we make. And as employers, if we start thinking about these determinants of health, if we're responsible for the health of the population, are we then responsible to try to positively influence some of these lifestyle choices? I would say yes. We do not own them. We cannot decide what our employees do or don't do, but we can be aware of them. And I believe if done right, we can have a positive influence on those decisions. It's not easy.
I so agree with you. And I think also the way you identified the corporate determinants of health was really, really helpful. It's something that we sort of don't really separate into different categories, or it's sort of a big mushy thing, but that really helped clarify.
Yeah, Mary Ann, that was, to me, was the biggest aha of COVID, is how corporations just ran to rather than from the disease. And so these are the things we've got to do to stop the spread, to contact trace. And we said, here's this disease. We as a corporation have to get in the fight. We just haven't done that in other conditions. But that's, I think, our opportunities to take that mindset of how corporations ran to the fight, and maybe we run to the fight in other things too. And I think we can win.
I think so too. And I think so many companies are no longer just business for profit. They really care about their employees. They understand that it's all part of one organization. And I think we've made some great strides in that regard. And I think you're right. COVID has accelerated the pace. So I mean, been a downside in so many ways, but there are some positives that are coming out of that. And we discussed some of the positives throughout today's and yesterday's programs as well, the telemedicine opportunities and the coordination of care and changing the workplace, making access so much better. So it's been a great. I hope that all of you who are listening in, who attended the programs, are thinking the same thing, that this was comprehensive, it was useful, it was meaningful, gave you some new insights, some new ideas, so to do your jobs better. And so I think, don't forget, we're going to be sending you a feedback survey. Tell us if we hit the mark or didn't, and we'll listen. And then